So I did my undergrad in the United States on a tennis scholarship and then found my way in Ontario, but I grew up in Victoria, BC. So then I did my master's in St. Catharines and loved that experience, earned a lot, gained a lot, but knew I wanted to leave sort of the academic world. So then I really just haphazardly stumbled upon to the PA program and applied, and then that worked. And being in Ontario, it was easy enough to head to Hamilton. So did the training there and graduated in 2012, and now it's hard to believe we've been working for that long. So I've worked in Toronto, Winnipeg, and now Edmonton.
Excellent. And I think you're one of the few PAs that have worked in 3 different provinces in Canada, which is very impressive. For sure. So what specialty do you work in right now?
So currently I'm in otolaryngology, head and neck surgery, formerly ENT, but the surgeons are trying to stay away from that term. I'm not really sure why the shift in that culture, but so ENT more widely known. And it's quite subspecialized. And then previously I was in cardiac surgery for about a year. Geriatrics really was only like about a 3-month stint, just to try to get my toes wet a little bit into some primary care. And then prior to that, general surgery with sort of focus on colorectal or surgical oncology.
Okay, excellent. Can you walk us through sort of a day in the life in otolaryngology, head and neck surgery?
Yes, otolaryngology. I've heard both pronunciations, so I think either way you're good. OHNS is sort of if you want to refer to that moving forward. So my shifts, I'm actually Monday to Friday, 7:30 to 3:30. So it's a great 8-hour work day. I arrive always about 45 minutes early. And for me, that's key. It's allowed me to, this is where I work on sort of my outside projects. So I'll work on my podcast, or I'll read some journal articles, or I'll write some journal articles, and just give myself about 45 minutes to sort of start my day. And then I have that awesome teaching for an hour between 7:30 to 8:30. So I'm very, very fortunate to have that. And really the residents or staff will give lectures. So it's a full 60-minute lecture in otolaryngology, which is fantastic. And then at about 8:30 to 9ish, we sort of run the list. So I don't round with the residents. The residents start their rounds at about 6 a.m. I'm fortunate I get to stay in bed or come early, as I had said. And then after we run the list, then we sort of disperse. And then that's when the patient care starts for myself. So we try to get the residents to the operating room and or clinic as soon as possible. And the procedural care on the ward can be tracheostomy changes, decannulations, pulling any percutaneous drains, making orders, following up labs, replacing electrolytes, et cetera, et cetera. So that's sort of, let's say between 9 and let's say about 11:30 or noon. And then of course putting out fires as they come. So when we have unstable airways on the ward, or not unstable, but if we have fresh tracheostomies on the ward, there's always things that can go wrong, desaturations, patients that require readmission to the ICU or anything in that. So of course dealing with those acute issues as they arise. And then I try to get to clinic myself, sometimes maybe about 2 times a week. Otherwise the ward is pretty demanding. And the resident team that I'm on, we only have 3 residents at a given time, and we have 2 hospitals that they operate on. So sometimes I find myself alone on the ward. So then it's sort of my role to, manage all those 20 to 30 patients, depending on how many we have. If there's time, I get to clinic. And if there's time, I also help the on-call resident. So one of those 3 residents is always on call. And of course, there's a lot of issues during the day that they have to deal with, nosebleeds or tracheostomies or acute airways, things of that sort. So I actually serve as, I'm sort of the first contact point from the attending surgeon who takes all the consults from the emergency department. And our catchment area in Edmonton is huge. So we take patients from Northwest Territories, Yukon, British Columbia, basically anything west, I believe, of Winnipeg comes to us. And then anything east of Winnipeg goes to Toronto. And then I'm not really sure how the Winnipeg service acts. But those are sort of the 2 primary centers, in my understanding, in Canada. So the surgeon will contact me with any emerge consults that come. And then I have to sort of recognize how urgent it is and then find the junior resident that's on call that day and alert them of the consult. And if I can get started on the consult while we're waiting as they're coming in through STARS, which is, I think it's the Ontario equivalent of the Team Orange helicopter transport. So that's sort of that. And then end of the day, I run the list again if I can, or if not, I send a little handover blurb via secured email. And then, I'm fortunate. My 8 hours is done and I sort of get to go home.
Excellent. So it does sound like you do call during the hours that you are there, and then you don't do call on weekend or in the evenings, right?
No, and I wouldn't even say that I do. It's just sort of, if you picture like a medical student model who's learning with the resident, like I'm very happy to go start the consult. I'm very happy to pre-admit people as well. So no, I wouldn't even say that I'm involved on call. It's just, because I'm the continuity, it's so easy for that surgeon to just contact me and then I disperse out the consult, as opposed to the surgeon having to be on top of the call schedule, which changes all the time with the residents anyways. So.
Absolutely. And is the surgeon reviewing every case with you? What is that relationship like?
It's hardly I see the staff unless I'm in the clinic with them. So really the chief resident and those 2 junior or intermediate residents that I work with are my team for that time. I would review the consult first with the junior resident who I've helped out with that. Or if it's easy enough, I just skip that loop of communication and I can just go straight to the senior. But it's really, it's still sort of like that hierarchical, model that we learned in, and I enjoy that still. So it's a great relationship that I have with my team. It's a really small program. There's about 2 to 3 residents per year, times 5 years. So there's 10 to 15 residents. So quite small, and we're all intimate, and we only get plastic surgery residents as off service. Otherwise, it's always the same people I'm working with. So there's really nice bonds and relationships formed with with the team that I have.
Yeah, absolutely. You really get to know them after a few months to years. So what would you say the most common conditions that you see in OHNS?
Well done.
Yes.
So because I'm on the head and neck team alone, so in otolaryngology, we have actually different subspecialties. So the division is quite large. And then within that, we have like rhinology, facial plastics, general ENT, and head and neck. So I'm allotted to really just the head and neck. So this is the oncology side of things. So definitely the most common thing that we see is any malignancy between sort of nasal cavity, pituitary down to the larynx and sort of hypopharyngeal area. So laryngeal cancer, tongue cancer, oropharyngeal cancer would be sort of the most common that I see. Acutely, if we're on call, we'll take patients of epiglottitis, neck abscesses. So those are probably the most common.
Okay. Any more rare conditions that you usually come across from time to time?
There's always weird, weird trauma cases, for instance, like, oh, I fell onto the knife and somehow it's in my neck, funny things like that. So I'll say penetrating trauma is pretty rare, but when it happens, it's interesting. It's always funny to say neck fash. So we get a couple of necrotizing fasciitis in the neck area. So there's debridements with them. So we've seen a couple of cool cases of that. And I also saw one really bad, like I can't even believe, like someone had severe profound sepsis from a pharyngitis, which is just so scary. Required intubation and operating just from a pharyngitis. So it's as benign as, a lot of our colleagues see as in the primary care. I'm fortunate enough, I guess I can say that from a weird, twisted mind, to see the sickest of the sick of these sort of common diseases, but more rarely they're really ill.
And do you see a pediatric population as well? Does that fall under your...
No, actually, Evan, I should say that it's another subset of our otolaryngology.
Of course.
We have 4 fantastic pediatric surgeons. No, I don't do pediatrics. I got to do 2 weeks sort of introductory of the whole division. So I went through all of those subsets, which was a great introduction to the role, which I really appreciated that the division could provide for me. But no, during the day, they have a pediatric day call resident who deals with all that. So.
Can you walk us through how they started you off in the OHNS department? Like, how did they introduce a PA, and did they know what to do with you when you arrived?
Not really. Everything was fly by the seat of the pants, which was, I kind of think it's a blessing because they were really flexible in terms of how we wanted to define the role. They know they needed help on the head and neck. So we knew ultimately that was going to be my starting. or that was going to be my destination. Starting, again, I had 2 weeks throughout everything. And then at each 2-week interval, Alberta Health Services wanted a review of sort of my performance or an evaluation. So every 2 weeks for the first 6 weeks, I had lots of feedback, which was great. And then after that 6-week rotation through everything, then I started July 1st, the new academic year. It was good timing with the new incoming residents. So it was sort of new for everyone. I think it's interesting because we have some residents who had junior experience without me, and then now they're still juniors, but they have experience with me. And so they've had that neat sort of overlap, and they've been really able to comment and help how the role has helped or how we could change it to make it better. And so I think the introduction was quite simple, actually. I'm very fortunate. And like we have just one ward that's otolaryngology. And so I got really familiar really fast with everyone. So
do you require any kind of medical directives in Alberta to practice?
yeah, it's different. So I signed, I tried to find the document actually just so I'm saying it correctly, but I think it was called a statement of supervision. And basically it was just a 1-page thing that Alberta Health Services had. And it just sort of said what you can do and what you are unable to do. And it certainly isn't exhaustive as medical directives. And it's sort of, it's a vague directive essentially that was signed. It has not yet been updated since I started, and I don't know if that's something. I think because we're in the works of regulation in the province, there's not as much onus or urgency in terms of modifying this document because we know it's happening. The legislation's still pending and et cetera, et cetera. But because CPSA has said that will be regulated, I don't think anyone's really harping on requiring more documentation, or I don't know. Okay. Maybe I'm naive about that. Yeah, it's hard to say, but there is a document that I did sign, all parties signed, but it's certainly not the process that I went through in Ontario.
Yeah. And we have a question from Becky, who actually runs the podcast Meet the PAs.
Right.
So she was curious about how it was like changing specialties, because you started in geriatrics, then, or not that you started out in geriatrics, you've been involved in surgery, you mentioned cardiac surgery, geriatrics, and now it's OHNS.
Yeah.
So because is it like starting from square one every time you switch specialties? Or what has it been like?
It sort of is. I think actually the most difficult transition was going, because I did the general surgery for 3 years, into geriatrics. And so that was probably the most difficult switch. I went from an academic resident team to a, sort of unilateral. I did have another team of 2 PAs, which was great. But just making that switch from general surgery to primary care was a bit, that was challenging. It's definitely more broad and superficial learning, but more knowledge. I came to learn about myself that I really just like to know more about one thing. So I think it's easy. That's why I've sought sort of surgical subspecialties, and I like surgery just because I like that population. I like acute care. Each time I did start a new role, so I've worked in 4 different areas of medicine, I guess I could say. And so each time it's definitely been sort of a, straight vertical learning curve. But each time I can bring sort of an experience with me into it. So although it is new, I think the adjustment has been less than if I had just started in that role. And I find this role is actually very similar to the role that I had in Ontario and Toronto at Mount Sinai in general surgery. Again, resident team, similar daytime hours, dealing with the ward management. So lots of crossover. But of course, this this area is a lot different than your abdomen. So it's just brand new disease processes, learning as you go. And that's what's so great about being a PA, right? Is just that flexibility.
Absolutely. It's almost like switching rotations every 4 to 6 weeks during clerkship. It's sort of brand new every time.
Yeah.
So we have a few questions about living and working in Alberta, because I know a lot of us are very curious about the environment there. So we have a pre-PA student, Brandon, that wants to know, what were some of the obstacles involved in obtaining employment as a PA in Alberta? Because he understands that there aren't as many positions available in Alberta as there are in Ontario. Or is that a misconception?
Yeah, so we don't have any, like Health Force Ontario, for instance, and McMaster and U of T providing all the new job postings via email and whatnot. Like certainly that doesn't exist in Alberta, lacking an education program at the moment, and lacking sort of the provincial, like that project, the designated PA project that Ontario has. I actually had little difficulty in achieving the position. I just sort of networked, found the contact who I needed to, sent an email, and they said, "Hey, we're actually interviewing for these two positions. Are you interested?" And within 7 days, I was on the phone with 2 surgical staff. So I'm so grateful. It was quite easy. But I know that if you go to Alberta Health Services, I think that they actually have like on the drop-down arrow, when you look for careers, they do have a physician assistant tab that's slotted. So I know that they exist. And like Ontario, Alberta is divided into zones. So Edmonton zone, I think, is very forward, progressive, and they also hire the clinical associates here, the CAs and PAs. So there's one gentleman who's sort of within human resources, that's our go-to guy for those roles. So I think if you can somehow find your way to him and find the availability there, they may not be posted, but half the job, from my understanding, it's all about who you know these days anyways, in terms of getting the positions. Mm-hmm. So I guess it's tough if you have sort of a new graduate who doesn't have experience and doesn't know who to contact. I can see that as being an obstacle. Like I said, I was really fortunate to find that contact quite easily. And I don't actually know if that individual is still employed. They do have a bit of turnaround in the government here, like Ontario. Those positions are always shifting. So I don't believe that person that I initially contacted is involved in PA employment anymore. And yeah, postings are scarce, but I think that it is possible. And then in South, I know that I have a lot of questions asking too about Southern Alberta. And Calgary seems to be a little bit more difficult to sort of penetrate, and I'm not sure why. I don't know if it's because they're in a different funding zone, and maybe they're just not providing as many positions there. Maybe they're leaning more towards the CAs as opposed to PAs. I'm not sure. So we're really far removed from the Calgary zone, so I can't really speak to that too much. But I think when the Calgary program comes, which I think has been stalled based on the regulation, when that comes, I think that will certainly help. So that's an obstacle too, is just not having the academic contacts, but that will come.
Yeah, and as we know, like you had mentioned, that there's no PA school in Alberta yet. So,
yeah.
What do you love about living and working in Alberta?
I was born here, so my extended family is here, which is great. Northern Alberta is fantastic. I mean, it was cold this winter, but I survived Winnipeg. I survived here. I find Edmontonians are incredibly friendly. Opportunities are great. It's been a very easy adjustment for me. I think it still offers metropolitan, but it's not the size of Toronto that after 3 years became a little bit overbearing for me. And so it's so easy to just 45 minutes, you're on the outskirts and you're in nature. And so for me, that's a big, as an outdoor enthusiast, that's lovely for me. So love it here. I advocate for anyone to come live in the area for sure.
Mm-hmm. Mm-hmm. And what's the PA community like in Alberta? Are there, do you guys stay in touch, or are there many of them actually from the Alberta area or surrounding areas?
Yeah, it's fantastic. I think so. The civilian numbers are increasing. It was retired military predominant, and I think that's when the PA demonstration project started here. I think that was most of their recruitment. In the hospital alone, I think there's 4 of us, civilian trained Ontario, who have come over. So there's been a little bit of a wave, which is awesome. And then the others are retired military or military. And one of them, she's done a fantastic job. So shout out to Cindy, who's actually arranged an Edmonton PA Journal Club, and she's got it accredited through the Royal College. So once a month, we've had 2 meetings now, and we have our next one next Thursday. We're getting the opportunity to present and review articles and critically acclaim them, and it's been a great experience. So she's done a great job in unifying us, and active military members are coming to those as well. So we're growing, and this is just Edmonton alone, and I can't speak to the other areas of the province. Again, I don't know how many are in Calgary or what's going on. But so no, there's at least 8 to 10 of us who are sort of connected, which is great.
Excellent.
Yeah.
And was there anything else you wanted to mention about your time working with residents or working as a PA in Alberta?
I think, no, it's a blessing. I think as I'm early on in our career, I don't mind being in this sort of, I hate to say hierarchical because it's not. We are still a team, but certainly I do sort of manage the ward in sort of the lower level decision making. I mean, I do the acute things, but for the upper decisions, that still has to go through the chief resident. But I think as we're early on in the career, the opportunities that have presented themselves being in an academic center on a resident team, you would not find in a community, I don't think, in a community position. So I'm so grateful for the rounds that I get to attend, for the sickest of the sick, for my, ability to, I see palliative patients, I see active patients, I see just the broad range of spectrum of illness that I get to see. And I like being on a resident team. They're all keen to learn. They're studying their butts off. It encourages me to study. And I think, again, if you're sort of in a one-on-one community practice, it might not be as promoted or encouraged. I could be totally biased on that, or at least the onus would be more on yourself. But when I'm in this environment of quizzing each other, pimping each other, the PGY5s are so stressed studying for their exam right now in 2 weeks. I just see how hard these individuals work to better themselves in the specialty, and it just, through osmosis, I just get that
secondhand. Or
so I love working with them, and since I'm under the age of 45, I feel like I can fit in at the moment. Who knows when I'm a little bit older, but I'm still going to want to be on a resident team with 22-year-olds. It's hard to say.
Fair enough. And are you in the OR, or is it primarily the residents that are using up that OR time?
It's definitely the residents. And that's sort of I want to get residents to the OR to enhance their OR ability. I'm envious. I did have more OR time in Toronto, which is okay. Again, it's very procedural on the ward, so I really try to, between the respiratory therapists and myself, I say, hey, can I do that tracheostomy change so that I can keep up with my skills? I do get the opportunity to operate if we do have multiple rooms or if the residents are spread out, but it is sort of far and few between, and I'm okay with that.
Excellent. Yeah. And have you been involved in PA advocacy recently?
Let's see. We have a legislature day coming up in Edmonton, which I'm really excited about. I think that's mid or late April. I'm excited to see Patrick and Natalie come out. That'll be fun. I have another publication in press, which is exciting, by the Canadian Family Physician. So I'll let Kappa know when I'm not sure which volume that will be in, but Maureen Taylor and I wrote a little commentary piece that's pending, which is great. I suppose my podcast, on a bi-weekly schedule, promotes PA advocacy. I don't know. I think just embracing my role, and, so we do it every day, just being present at work and contributing. I feel like that's advocacy as well. So.
Excellent. And so I know that every year that I go to Kappa, you always have a poster or some kind of research that you're presenting. Even when you're not actively in research, there's always a poster that you're doing. Yep. Go Oilers. So how can other PAs who have no experience getting involved, what can they do to get involved with research or poster presenting? Is it hard? What's a way to get started that you'd recommend?
Yeah, I think it's quite simple. I think for me, I just really reflect first, what do I bring to the table? And how did that differ from before the PA role that was present? And then how can I measure that contribution? So that's really sort of what I think about. What am I finding that I'm doing that's improving quality of care, improving physician work-life balance, anything, and then try to come up with measures to provide that, either ideally quantitatively or qualitatively if you have to. And then just coming up with a research question. You can use PICO, or you can use any sort of way to get there. Mentorship is always great. So if you have an idea, talk to your supervising physicians. Look at the previous articles in the JAPA. There's lots of, that's a great publication. I don't read it as often as I should, but we have access to that as CAPA members. Read the articles, see what other people are doing, and you can even mimic their own, and then just reference their study protocol. I do think it is quite simple. I think the thing is that you just can't expect to be compensated. It does have to be sort of your own within yourself that you would want to do this. I know that, some colleagues have said, I would love to do this, but, there's just no means for it. And no, there isn't. And I think that's why I come 45 minutes early in the morning, and I just devote that to either generating a protocol. I'm doing a clinical trial right now, actually. So, coming up with the ideas for that, writing the proposal and the ethics application for that, that's what I do, when I start my day, before I start the day, I should say. So I don't think it's difficult. Just be creative, find ways that you can measure your contribution, seek mentorship, measure those ways. This analysis is always exciting. Hopefully you can find a difference, and then put it on a poster. And I think CAPA, we have our layout that we follow. And so, and I've done some really sort of, not the one that I did about changing specialties or a couple of years ago, like it wasn't mind blowing, it wasn't profound at all, but just that opportunity of being able to articulate your thoughts in an academic way. It's a different type of style of writing. And so having that opportunity to do that, presenting it in front of colleagues and creating a poster, I think it's quite simple. So I'm happy to help anyone if they have any ideas and they just don't know where to get started. I think it's just, just put your head down, really reflect, and then go. And then don't, maybe you can find funding, but I think it sort of has to be within that you would want to do research like this.
Yeah, exactly. Because we have a lot of data that's stored in our electronic medical record system. So right. It's literally just looking at the billing file or the appointment list of what the appointments look like before and after a PA was introduced.
Yep.
I get intimidated by statistical analysis. So what would your suggestion be? Would it be worth contacting a statistician, or are there very simple ways that we can kind of analyze our data without feeling overwhelmed?
Yeah, no, that is, and I did my master's, and even then, and I did a statistics, 2 statistics classes, and already there are 2 great resources, Anne, that I can send you that our founding, we have a physician mentor in our Edmonton Journal Club who's provided 2 great statistics books. And he said they're easy reads and they're awesome. And so if you know sort of what test you want to do, or if your variables that you want to compare, you can really, he said, I haven't read these books, but I'll forward you the titles of those. I'm sure that he wouldn't mind me sharing those with you at all.
Yeah, that would be helpful.
Yeah, for the trial that I'm doing now, some of this, because the statistics are a little bit more challenging, but I just asked one of the residents who's currently doing a PhD MD, which is, mind-blowing, good for him. So he's going to help me out with that. And then to his credit, I'm going to, if it does get published or anything, he'll of course have co-authorship and help me out with that. So no, that can be daunting. I think that's where mentorship is helpful, and just finding easy reads. If you're doing qualitative stuff, it's quite simple, just measure things on a scale, a Likert scale, 1 agree, 5 disagree. And there are ways to measure those. I think you can keep it simple though. And, if a paper were turned down because of poor statistics or the way that your data was analyzed, then maybe you could at that time reassess things and maybe get some help from someone. But certainly I've never approached a statistician. I've just sought mentorship who knew more than me and said, this is the data, this is the equation that you have to do, here are your variables, punch in these variables, and there you go. And using SPSS or Excel, you can get away with it.
Great. I haven't used SPSS since undergrad, so
exactly.
It's been a while. So sorry, there was a question I missed about working as a PA. So as a PA, what do you find are possible obstacles or benefits in team dynamics? Or how are your working relationships with other team members?
Yeah, there's always personality clashes and everyone's different. Our chief residents change over every 3 months, I believe. So in a given year, I'll have sort of 4 different leadership opportunities where that individual will be my go-to person. I don't know. I think having the intimate, smaller residency program really makes it easy for me to accommodate to what their preferences are. Whereas if you have a larger program, I know one of my colleagues, she's in urology, for instance, big program, lots of incoming residents. I could see how that would be challenging with lots of turnover. Again, I just have a small number of on service, so it's quite simple. Mm-hmm. The staff that I work with, they're 4 male staff. We all get along fantastically. Again, I'm so fortunate being in this sort of prestigious academic center where people are, the criteria for them to work at this hospital means that they have to be considerable leaders themselves, and their resumes and curriculum vitae are just so impressive. So I'm working with fantastic, lovely people, and I'm super lucky. Does it get challenging? Absolutely. This is where, and it also depends on the leadership of that person. Some are more hands-off and some aren't. So just knowing, I know them well enough now that, okay, I need to ask for this decision, I can make it on my own and I'll review with them after the fact, or for this decision, I need to go talk to them first. So it's just understanding, as your role as a PA, what do you need to, I don't want to step on toes. And so that's just when you need to know how to navigate your way through the decision.
Mm-hmm.
Mm-hmm.
And I understand that you were a class of 2012 at Mac, right?
Yes.
Yeah, so you were actually the year after me. And I know at that time there weren't a lot of civilian PAs working within Canada that we had access to as pre-PA students. So how did you determine PA was the right career for you? What drew you to the profession?
Yeah, as I said, it really was stumbling. On my graduation day from my master's thesis, I bumped into our program director, who, Laura McPherson, your colleague, she was also, so she finished her kinesiology degree. We were in the same program, master's. I think she did her master's of arts, but I did my master's of science. And he said, what's next? And I sort of said, I'm not sure. I didn't think I wanted to do my PhD at that time, so I knew I was going to take a year off regardless. I needed to really figure out what I wanted to do. And so this program director said, well, Laura has applied and made it into this physician assistant program. And I said, oh, well, what is that? And literally that's how it happened. I had written the MCAT that year. I performed poorly. It was at the same time of my dissertation, so I didn't get in Canada. I got in abroad, but I thought that was a big insecure step, and I wasn't ready to do that quite yet. I said, let's try either one more time, see if medicine is really what I want to do. And so I stumbled upon the PA program, and I know that I know the admissions process is much more challenging these days than when you and I sort of were getting into it. So it was, is it for me? Absolutely. I still have such an active lifestyle, and I'm still able to practice the awesome specialties that I've had, and being in the academic centers, I'm working with the best of the best. And so I'm just on cloud nine right now, and job satisfaction is a big part of my life. I don't have any children or family. I have 3 dogs and a better half. And so it's when my job is happy, sort of everyone in my community is happy. So it's, for me, it's such a big, important thing. So I'm I'm just happy. It's great here.
Excellent. And so we have a lot of questions about how you prepared as a pre-PA student. So I think at that time you probably didn't qualify to apply to U of T because of their primary care or direct patient care experience requirement, which they've changed, and that's evolved a little bit over the years. But what did you do to prepare for PA school admissions?
Mm-hmm.
I know this is going a little bit back, but
can I remember 6 years ago? My gosh, it's been that long.
Mm-hmm.
I think I was sort of, again, I was caught in that midway where I was still defending my thesis and trying to get that completed. So I know that was a lot of focus in my life at that time, despite having just completed the application for the PA program. But preparation, I'm not sure, to be honest, if there was much incredibly. I think going back, I would definitely sort of looking of advice then for future pre-PA, I would just say, get on your anatomy and physiology. And if you can just sort of get that down, being kinesiology, I really sort of knew MSK stuff, a little bit of cardiovascular physiology, but really just reading a simple anatomy and physiology textbook just to get that underlying medicine would help, I think, going into the lectures. Or into the PBL experience. So I can't say that I read an A&P text, but that would be something that I would say to others moving forward.
Those are students that are going to go to, who have gotten into the program that are getting ready for first year?
That's what I think. I mean, why not? You have that summer, or you have the summer coming up before the August or September start. Again, I can't remember when the program starts, but maybe good summer reading when you're on the beach, not so much. The internet has a lot of neat flashcards and things like that. And so trying to make it fun, at least, I think just having an overall systems review would be good, because as the PBL is defined in those systems, I think that would help. But I'm sorry, I can't. I don't know if I prepared prepared too much, to be honest, and just sort of accepted that this was going to be a challenge. And here we go. And it was the toughest 2 years of my life. I will say it was more challenging than my master's thesis. And just for those who are going in, just be ready. And the sky's the limit to your learning, and it's really what you want to do.
Excellent. And given all the challenges that we have in Canada, like we are trying to be clinicians practicing medicine, there's a lot of PA advocacy we have to do in terms of introducing ourselves into different provinces, regulation, funding models. What would you consider someone that would be ideal to become a PA in the kind of environment that we have here in Canada, in your opinion?
Yeah, no, I mean, I think I was very impressed with a lot of the presentations that we had in Ottawa. A lot of the physician assistants had given the presentations, which was a bit of a shift from our other conferences being mostly physician led. So it was so refreshing and so nice to see that others are taking this leadership and this onus on saying, this is a PA, this is what I've learned, and let me teach you about my medicine. And I think that was great. So more, if you're a self-starter, if you're not afraid to be curious and put yourself out there, again, it is a fine balance, because we can't, we are supervised. And so it's negotiating those relationships to make sure that you're still appeasing your supervisor, but still advocating on your profession. So it is a difficult balance. So having that judgment and having that ability to reflect, well, this, maybe I should have approached it this way, or, so someone who's a self-starter, someone who likes to reflect on behavior so that they can modify it as necessary, someone who, I think is just not afraid to put themselves out there, because really you create a role, because a lot of the places wouldn't have had PAs before. So you have to be flexible and willing. There's going to be challenges in accepting that. So you have to be a flexible individual. I don't know. I think those would be some of the characteristics that I would define.
Yeah, exactly. And I actually see a lot of those characteristics in you as well. So I think we're extremely lucky to have you as part of the profession.
As with you.
Oh, thank you. Thank you. Yeah, you actually answered all of my questions. I thought this would go on for 2 hours, but it really, no, you were so good and so concise. So what's next for you, I guess, is my next question.
What's next? I'm excited. The clinical trial, it's quite small. Again, they're just small little measures, but I'm just seeing if I can improve the discharge process. And so hopefully I can find a difference. I have to recruit 32 patients, and I've recruited 8. So I'm 25% of the way through my patient recruitment. And so hopefully by late spring or so, I'll have all that data that I could start looking at, and maybe try to get another publication on the go. Still generating a new podcast episode every 2 weeks. That's my goal. I'm very excited. I'm actually going to an ENT conference for PAs. So special, so niche-y, in Arizona at the end of April. So that's exciting. So I'm starting to look to the States for subspecialty opportunities. And I asked, can a Canadian come? And they said, absolutely, you'll be our first. And so that's exciting. So I'm going to have some great CME that is literally just geared towards everything that I see on a daily basis, which is great. So that's exciting. Of course, Kappa in Victoria, I won't miss it for the world. That's my hometown. So an excuse to visit my nieces and sister and mom, and of course, meet the Kappa community again. And just enjoying my summer here in Edmonton, camping every weekend because my schedule allows it, and this city does too. So
that's fantastic. And it's you've got this beautiful scenery and landscape that's just so accessible. So I know that you're fairly active in outdoor activities.
Yes.
So it must be just a dream living there.
It is, yeah. So I get to drive 10 minutes today and go cross-country skiing. It's pretty, it's a great Canada, it's such a vast nation, and we've done such a good job unifying it, but each province has its own little gem, and I love it here for sure. So
great.